Welcome to the G6PD Deficiency Foundation's Medical Education Module. Got the D? Recognizing glucose 6-phosphate dehydrogenase deficiency and improving outcomes in newborns. As you may have guessed, D stands for deficiency. By the end of this educational module, learners will be able to identify the prevalence of G6PD deficiency in your patient population, understand screening guidelines and the pathophysiology of this condition, describe potential long-term clinical outcomes, understand the importance of screening neonates for G6PD deficiency and the impact of screening on patient management, and describe the different types of G6PD deficiency testing, including the benefits and drawbacks of each particular testing modality. The patient is a newborn baby boy, born via simple vaginal delivery at 35 weeks and 4 days gestation. His mother experienced an unremarkable pregnancy and attended prenatal care regularly. The newborn is of Mediterranean European descent. His examination at birth, facial jaundice, was present. Significant to this evaluation is the 2-year-old's brother's history of neonatal jaundice. The brother did not require phototherapy. This newborn is otherwise healthy. For newborns, bilirubin tests are used to guide the use of phototherapy, timing of follow-up, and escalation of care to avoid the occurrence of hyperbilirubinemia. Shown here is an hour-specific bilirubin nomogram provided in the 2022 American Academy of Pediatrics Revised Guidelines for neonates who are born on or after 35 weeks gestation and who have no hyperbilirubinemia neurotoxicity risk factors. Under normal circumstances, bilirubin levels tend to increase after birth, gradually leveling out over time. Plotting the newborn's bilirubin measurements against his or her age in hours on this nomogram provides critical information about the need for phototherapy. If the neonate's bilirubin falls at or above the threshold line identified for the neonate's age in hours, it is recommended that phototherapy is to be initiated to circumvent hyperbilirubinemia. This list is from an update to the 2022 AAP guidelines. It provides an outline of the risk factors for hyperbilirubinemia. Younger gestation age, jaundice onset in age hours, bilirubin levels in high-risk zones, and known hemolytic diseases are among those factors that should be monitored. Infants who are breastfed and feed poorly or who lose weight, and macrosomic infants of diabetic mothers should also be closely observed. Phototherapy is the most commonly used therapy for hyperbilirubinemia. This therapy is used to reduce total bilirubin levels, to lower the potential need for exchange transfusions, and to reduce the risk of neurological damage. When a neonate with hyperbilirubinemia is unresponsive to phototherapy, exchange transfusion is indicated. Susceptibility to neurotoxicity increases when a neonate who is born at or after 35 weeks gestation has hyperbilirubinemia and one or more of the listed risk factors. The decision to initiate phototherapy or to proceed with an exchange transfusion will be guided by the risk factors applicable to the neonate. Generally, when any of the neurotoxicity risk factors are present, it is recommended that therapy be initiated at the bilirubin level lower than that used for patients who are not subject to these risk factors. Going back to the case presentation in hand, let's use this bilirubin nomogram for the neonate without neurotoxicity risk factors. One can see that at 18 hours of life, with visible facial jaundice, our neonate's bilirubin was 6 milligrams per deciliter, and definitely below the phototherapy threshold. At 48 hours of life, just prior to discharge, the neonate's bilirubin was 13 milligrams per deciliter, which placed him nearer to the threshold for phototherapy initiation. Take note that his jaundice was visible to his hips. The AAP recommends different follow-up treatment plans when phototherapy is not initiated. Those treatment plans are based upon the neonate's bilirubin level, gestation age, the presence or absence of neurotoxicity risk factors, and the gradient between the bilirubin reading to that of the level at which phototherapy should be initiated. PediTools provides a calculator that can assist with the construction of an individual treatment plan for every neonate. On this slide are snapshots of the PediTools treatment plans recommended for the neonate in the presented case. As you can see, this tool helps determine the next step for the follow-up treatment. The AAP 2022 revised guidelines provide a second graph that should be used for neonates born on or after 35 weeks who have at least one neurotoxicity risk factor. This graph represents the bilirubin phototherapy thresholds for such neonates. These thresholds are lower than those found on the nomogram used for the neonates who have no neurotoxicity risk factors. Bilirubin levels in neonates with G6PD deficiency do not follow the pattern seen with those who have no risk factors. Instead of a predictable arc, bilirubin levels in G6PD deficient neonates have the potential to rapidly increase over time. Because G6PD deficiency enumerates among the risk factors that can cause hyperbilirubinemia neurotoxicity, this is the bilirubin nomogram that must be used when assessing the bilirubin level of a neonate with G6PD deficiency. If you learn that this newborn has a known history or a familial history suggestive of G6PD deficiency, would this change your management of the patient? Yes. Upon further inquiry, the mother of the neonate in the case presented reports a family history of G6PD deficiency. With the knowledge that the neonate may possibly be G6PD deficient, a condition recognized as hyperbilirubinemia risk factor, it would be prudent to use the risk factor nomogram when constructing a treatment plan for this infant. With an initial serum bilirubin level of 6 milligrams per deciliter, although that level places him below the threshold level set to initiate phototherapy, management of the patient should be guided by his potential susceptibility to injury due to hyperbilirubinemia. It is also important to note that at the 48-hour mark, phototherapy would be recommended here due to the neonate's serum bilirubin level of 13 milligrams per deciliter. Use of PediTools to evaluate a neonate with one or more neurotoxicity risk factors reveals a course of treatment different than which is recommended for the infant without any risk factors. Specifically, the bilirubin level at which phototherapy should be initiated for the neonate with at least one risk factor is lower than that recommended for the neonate born without any risk factors. Based on his gestational age in hours, bilirubin level, and potential neurotoxicity risk factor, phototherapy should be started and his bilirubin levels monitored closely. Additionally, a quantitative test to determine this infant's G6PD activity level should be performed to confirm whether he is G6PD deficient. Due to the potential for a false negative during a state of hemolysis, this test may need to be repeated when the infant's bilirubin level is within a normal range. Because hemolytic crisis is a condition associated with G6PD deficiency, this infant's risk of being unresponsive to phototherapy is elevated. For this reason, management of the patient by the clinician in the neonatal intensive care unit should be considered. Because G6PD deficiency places the infant in a high-risk group, and inclusion in that risk group changes the patient's management protocol, when should you consider G6PD deficiency in your differential diagnosis? Listed here are facts to be evaluated when G6PD deficiency is being considered among your differential diagnoses. It is important to realize there are numerous malaria endemic countries besides the areas mentioned that have G6PD deficiency in their population. Areas in Latin America, such as Brazil, Colombia, and Cuba, are reported to have a prevalence of G6PD deficiency greater than or equal to 10%. We also have to consider that no particular race or ethnicity is immune from inheriting G6PD deficiency. Certainly, if you test all newborns for G6PD activity level prior to discharge, you will most certainly know what treatment plan to follow before that infant leaves your care. Determination of the G6PD activity status before discharge is in accordance to the AAP recommended approach to ensure the well-being of all newborns. Here are a few critical facts about G6PD deficiency. It is the most common hereditary enzyme disorder in humans that affects red blood cells. Worldwide, more than 400 million people are G6PD deficient. G6PD deficiency is highly prevalent in Africa, Asia, the Mediterranean, and the Middle East. In the United States, the prevalence of G6PD deficiency ranges from 0 to 13%. Males of African descent are the ethnic group most affected by this condition. Because clinical penetration is low, there is no regular screening regimen for newborns in the United States. For this reason, G6PD deficiency is often overlooked, which places the affected newborns at risk for significant sequelae, including bilirubin encephalopathy. G6PD deficiency is an X-linked recessive trait. Because males have only one X chromosome, G6PD deficiency is identified more frequently in males than in females. Some important points to note about this inherent pattern include: all males with the G6PD gene mutation are going to express this disease. These males will pass the trait on to any daughter born. Heterozygous females with the G6PD gene mutation have a 50% chance of passing the gene on to their sons and daughters. Those sons who receive the affected X chromosome from their mother will express the disease. Those daughters who receive the affected X chromosome from their mother may express the disease depending upon their respective level of X inactivation if the other X chromosome is normal. Lionization is the term used to describe X inactivation. Essentially, when lionization applies, the affected X is active in some cells, and in other cells, the affected X is turned off and is thus inactive. Because heterozygous females are subject to this skewed X inactivation, there is a spectrum of expression of the disease. The more the abnormal X is expressed, the lower the threshold for expression of G6PD deficiency. and the more likely the female will develop a hemolytic crisis in the face of oxidative stress. A female can have two affected X chromosomes, also known as homozygous for G6PD deficiency. For those women, the disease will manifest like males with this enzyme mutation. Oxidative injury to red blood cells can lead to acute hemolysis. In red blood cells, this hexose monophosphate shunt is responsible for dealing with oxidative stress, protecting the cells against hemolysis. Glucose 6-phosphate dehydrogenase, or G6PD, is the first component needed for the hexose monophosphate shunt. Under normal conditions, oxidative stress, introduced through oxidizing drugs, or infection increases the levels of pro-oxidant molecules in red blood cells. G6PD, along with several other enzymes, helps the body process the oxidative stress in a way that is not harmful to red blood cells. Those who are G6PD deficient have difficulty managing the introduction of oxidants into the body. Without sufficient G6PD, NADPH and reduced glutathione decrease as level of oxidants increase. This creates an oxidative state that causes damage to the integrity of the red blood cell membrane. Acute hemolysis follows. In newborns, intermittent acute episodes of hemolysis, in combination with a reduced ability to eliminate bilirubin in the early neonatal period, greatly increases the risk of severe hyperbilirubinemia. These are slides of blood smears with cells showing signs of hemolysis. Without reduced glutathione, hemoglobin oxidizes, denatures, and then binds to the membrane of the red blood cells. When in this state, the red blood cells are referred to as Heinz bodies. Oxidized hemoglobin also gives rise to bite cells, seen in the figure on the right. What appears to be a bite mark in the cell results from the mechanical removal of denatured hemoglobin as red blood cells pass through the spleen. The World Health Organization has constructed 5 clinical classes of G6PD deficiency based upon the degree of enzyme activity and the severity of hemolysis. Class 1 is the most severe form of the disease, but is also the rarest. People with Class 1 G6PD deficiency have an enzyme level less than 10% of normal. As a result, those in this class experience hemolytic anemia constantly. Those in Class 2 also are severely enzyme deficient and have an enzyme level less than 10%. However, they experience hemolysis intermittently and usually as a direct consequence of an inciting agent, such as an infection, certain foods, drugs, or chemicals. Class 3 individuals have enzyme activities that range from 10% to 60% of normal. People in this class also experience intermittent hemolysis, although less frequently than those in Class 2. Those in Class 4 have no enzyme deficiency, and those in Class 5 have a higher than normal G6PD enzyme level. Because people in these classes have sufficient levels of G6PD, they are not subject to the sequelae caused by a deficiency, and thus will not be a focus of this clinical discussion. It is important to note that the WHO began revisiting these classifications in 2019, and that it may revise these classifications in the future. In addition to enzymatic level and rate of hemolysis, the World Health Organization has also classified neonatal presentations based upon specific clinical manifestations. Neonates with Class 1 G6PD deficiency present with jaundice and anemia during the early postnatal period. Experiencing chronic hemolysis, these infants are at immediate risk to develop severe hyperbilirubinemia. Neonates that fall within Class 2 or Class 3 G6PD deficiency are those most commonly seen in a clinical setting. Because jaundice traditionally increases on day 2 or day 3 of life, at the point of discharge from the birthing facility, newborns in Class 2 and Class 3 generally present with jaundice and anemia that does not meet a threshold of concern. These G6PD deficient infants remain at risk for developing permanent neurological damage from hyperbilirubinemia if hemolysis continues. Class 4 and Class 5 neonates are not subject to chronic hemolysis as they have normal or above normal G6PD levels. When a neonate's bilirubin level meets the hyperbilirubinemia threshold, the potential exists that the infant will develop encephalopathy. The following 2 categories are used to describe development of encephalopathy due to hyperbilirubinemia. Acute bilirubin encephalopathy, or ABE, is the term used to describe clinical manifestations of severe hyperbilirubinemia, such as lethargy, hypotonia, high-pitched cry, and seizures. When chronic and permanent sequelae of extreme hyperbilirubinemia are observed, such as chorioathetoid cerebral palsy, developmental delay, hearing deficit, ocular motor disturbance, especially upward gaze, dental enamel dysplasia, and mental deficiency, the term used to describe this condition is chronic bilirubin encephalopathy, or CBE. Kernicterus is a term traditionally used to describe the pathologic effect of deep yellow staining of neurons and neuronal necrosis of the basal ganglia and brainstem. However, clinicians often use kernicterus interchangeably with the term chronic bilirubin encephalopathy. More recently, the term kernicterus spectrum disorders has been proposed to describe all conditions associated with hyperbilirubinemia. Motor and auditory symptoms determine the infant's position on that spectrum. Auditory symptoms range from mild to severe hearing loss. Those who are profoundly deaf and have a total lack of auditory brainstem response fall within the severe category. Similarly, motor symptoms range from mild to severe. Those with poor muscle tone, athetoid cerebral palsy, and an inability to speak, feed, or walk fall within the severe category. Bilirubin-induced neurologic dysfunction, or BIND, is a general term that includes all neurological consequences stemming from excessive bilirubin levels. Importantly, these conditions occur when bilirubin levels measure below the range associated with kernicterus. BIND sequelae occurs when elevated bilirubin triggers the inflammatory cascade, a response that affects characteristic areas of the central nervous system. Milder neurologic conditions result that have not always been attributed to hyperbilirubinemia. As such, moderate evaluations of bilirubin are no longer considered benign. Rather, such evaluations are thought to be potential contributors to deficits in attention, execution function, and learning. Interestingly, the long-term effects of hyperbilirubinemia have been studied. Those results provide insight into the impact of infant hyperbilirubinemia on the adult. In Finland, a follow-up study was conducted on a cohort of full-term and normal-weight newborns whose bilirubin levels were greater than 20 milligrams per deciliter. 368 term newborns with birth weights greater than 2.5 kilograms and at least 2 bilirubin levels greater than 20 milligrams per deciliter were followed. Assessed at 5 years of age and again at 9 years of age, the subjects underwent neurodevelopmental, intellectual, psycholinguistic, visual perception, reading, and spelling tests. At the 30-year mark, the subjects submitted to an extensive questionnaire that sought information about educational and occupational outcomes, social functioning, life satisfaction, substance abuse, physical and psychiatric problems. Results indicated that neonatal hypobilirubinemia negatively impacted the affected individuals during their adult years. Nearly half of the hyperbilirubinemia group was affected by cognitive inabilities in childhood that continued into adulthood. Also, ADHD, social and academic problems, and alcohol use persisted in adulthood. In light of this data, the authors concluded that neonatal hyperbilirubinemia is a recognizable cause of adult neurobehavioral problems severe enough to have negative occupational and quality of life effects. Shifting the focus back to infants affected by elevated bilirubin levels, data supports that G6PD deficiency is a major cause of brain damage caused by hyperbilirubinemia, or kernicterus. In a pilot study that resulted in the construction of the kernicterus registry, 125 patients who developed kernicterus were enrolled between 1992 and 2004. G6PD deficiency was identified as the most common etiology for kernicterus in that patient population. In September 2022, the American Academy of Pediatrics published a clinical practice guideline revision regarding management of hyperbilirubinemia in the newborn infant whose gestational age is 35 weeks or more. Critically, the AAP now recognizes G6PD deficiency as a cause of hazardous hyperbilirubinemia that could lead to kernicterus. In the United States, most postpartum patients are discharged between 24 hours and 48 hours following delivery. Many infants are discharged with some degree of jaundice. Since screening for G6PD deficiency is not universal and is not routinely performed, there exists a hidden risk that an unknown G6PD deficient infant will develop severe hyperbilirubinemia and possibly permanent neurological sequelae following discharge. Parents are not trained to recognize significant jaundice. By the time a parent recognizes that a problem exists, it may be too late to prevent sequelae. For G6PD deficient infants, elevated bilirubin may only be detected days after discharge. Also crucially important are the economic and social factors that may impact the ability to seek follow-up care. Noting how these hidden risks can lead to dire outcomes, the need for G6PD deficiency testing prior to discharge is critical. Unfortunately, neonatal testing for G6PD deficiency is not performed routinely in the United States. Two entities known to make recommendations about newborn testing, the American Academy of Pediatrics and the World Health Organization, have differing guidelines. As noted here, the American Academy of Pediatrics recommends testing newborns who are receiving phototherapy and whose family history, ethnicity, or country of origin suggests an elevated risk for the deficiency. Also, testing is to be performed if the infant's response to phototherapy is poor and if the infant has been readmitted for hyperbilirubinemia. In 1989, the World Health Organization recommended that universal newborn screening should be undertaken in the populations with a G6PD deficiency frequency of 3 to 5% or more in males. Currently, screening tests for G6PD deficiency are available for use with newborns. However, use of these tests in U.S. birth hospitals is limited, in large part due to a lack of knowledge about the condition. Also, no national consensus has emerged regarding the need for newborn G6PD deficiency testing, either with respect to the efficacy of screening or the manner in which the screening should be conducted. As of June 2022, New York is the only state that requires newborns to be tested for G6PD prior to discharge from the birthing facility. Other countries routinely test for G6PD deficiency. Screening for G6PD deficiency by these countries has resulted in a reduced incidence of infants affected by severe hyperbilirubinemia and kernicterus. Despite the prevalence of G6PD deficiency in the United States, which equals approximately 2 to 3% of the population, and with an overwhelming 13% in African American males and 4% in African American females being deficient, it is remarkable that the United States does not universally screen for G6PD deficiency. Problematic are the types of tests used and the timing of the performance of those tests. Where testing is conducted, the types of tests available do not always provide reliable results. Timing of testing is also important, as a state of acute hemolysis can lead to a false negative result. When the test is performed too late, the condition may only be recognized after the deficiency causes irreversible neurological damage. Barriers to learn about G6PD deficiency include a lack of awareness about the condition, the quality of testing available, and the ability for an individual to have access to the testing. Let's discuss the different testing options that are available and the limitations of certain G6PD tests. The fluorescent spot test is a qualitative point-of-care assessment. As the most widely used test for pre-malaria treatment, it involves placing a drop of blood on a filter paper that is then illuminated with ultraviolet light. With normal G6PD levels, the spot will fluoresce brightly after being exposed to UV light for 10 minutes. Blood spot with mild or moderate G6PD deficiency will fluoresce, but not as brightly as the blood from an infant with normal levels. Blood from those who are severely deficient will not fluoresce. Problematic with this test is the detection of heterozygous females, as it does not accurately detect female infants who are heterozygous for the deficiency. Qualitative tests do not give a numerical value and are known to cause erroneous conclusions. Also, a false negative may result if the neonate is actively hemolyzing. Spectrophotometric testing is a quantitative test. This type of analysis provides the individual's actual enzyme level as a numerical value, which usually requires more than one drop of blood. Because it provides a range of enzymatic activity, G6PD deficient heterozygous females will be identified using this test. However, those heterozygous females whose enzyme level is on the higher end of the spectrum that fall in the normal range of G6PD activity will be missed as carriers. Care must also be taken to evaluate for false negative results in babies that are actively hemolyzing. Hospitals that have a spectrophotometer in-house are capable of completing this type of analysis within hours. This assay, also known as the enzyme ratio assay, measures G6PD and 6-PGD activities separately. Subtracting out the 6-PGD activity provides a more accurate measure of G6PD activity and improves the sensitivity that allows for detection of heterozygous females and any other patient who has moderate enzyme activity. Use of this assay is not affected by hemoglobin concentrations, the presence of thalassemia, unstable hemoglobin, erythrocyte membrane defects, or increased mean corpuscular hemoglobin. Molecular testing is very accurate, but it tests for known variants only. There are 300 known variants of G6PD deficiency, but only 180 variants cause the individual to be deficient. Genome testing will not be affected by hemolysis. However, molecular testing is not practical due to the unavailability of the technology, too long of time for results, and the cost involved. Also, this test does not provide an enzyme activity numerical value, so heterozygous females will not learn their respective level of deficiency. A point-of-care test that provides G6PD activity in units per gram of hemoglobin is now available. Using a very small amount of whole blood, G6PD enzymatic activity level of the neonate can be learned in 15 minutes. Like many of the other tests mentioned, G6PD levels may appear falsely elevated during or right after a severe hemolytic crisis because of higher G6PD levels in the new red blood cells. However, with this device, samples with excessive hemolysis are flagged. The flag and its descriptions are readily displayed below the results. Thus, care must be taken to evaluate an actively hemolyzing baby, and the test should be repeated under the recommendations of the American Academy of Pediatrics. Interpretation of the results are according to WHO Guideline 7, titled Guide to G6PD Deficiency Rapid Diagnostic Testing to Support P-Vivax Radical Cure. It states, for males and females that have less than 30% of normal enzymatic activity are deficient. Males that have activity greater than 30% are normal. Females that have activity between 30% and 80% normal activity are considered to be intermediate. Females with activity greater than 80% are normal. This device is better to recognize the heterozygous females. However, as with any of the enzyme activity tests, the few heterozygous females whose enzyme levels fall in the normal range of G6PD activity due to lionization will be missed as carriers. However, at the time of birth, the important purpose of screening for G6PD deficiency is solely to prevent hyperbilirubinemia based on the baby's G6PD activity level. While there are several available tests, clearly some are more accurate and provide more data than others. However, some are not ideal for use in the acute setting or for population screening. Presented on this slide is a summary of the 5 testing modalities we've just reviewed. Collectively, taking all of the information presented here, screening newborns for G6PD deficiency should be undertaken in the United States for the following reasons. Population heterogeneity from immigration and intermarriage has increased, which makes targeted screening less effective. If G6PD deficiency history is unknown and the neonate's lineage does not suggest the need for testing, the neurotoxicity risk factor nomogram may not be used, which could result in irreversible damage that could have been avoided. Point-of-care testing make diagnosis easy and possible. And pediatricians support testing for G6PD deficiency, as it will assist with differential diagnoses. G6PD deficient infants are more likely to need phototherapy, and they comprise a large percentage of hospital readmissions. Phototherapy and exchange transfusion are therapies indicated for G6PD deficiency infants at lower bilirubin thresholds. Bend has been shown to occur with bilirubin levels previously thought to be benign. Other triggers for hemolysis, such as foods, medications, and infections, may not be avoidable or preventable. The incidence of kernicterus in countries with newborn G6PD deficiency screening is demonstrably lower. An analysis of the cost-benefit ratio supports that early detection of G6PD deficiency is beneficial fiscally, and fragmented care and early discharge puts the infant at increased risk. Simply put, the solution is to require universal newborn screening for G6PD deficiency in the United States. To accomplish this, newborns should undergo a quantitative test prior to discharge. Families need to be educated about the deficiency, not only to explain how to manage the condition, but also to explain that this condition is 99% genetically transmitted, so one or both of the infant's parents are most likely G6PD deficient. Clinicians also must be educated about how hyperbilirubinemia can lead to the conditions associated with Bend. These are pictures of children with kernicterus. Both of these children were healthy at birth. However, because their respective deficiency went undetected for days following birth, encephalopathy developed. With appropriate screening, intervention, and testing, their brain damage could have been avoided. Alone, these instances serve as a seminal reason why G6PD deficiency screening for all newborns must be undertaken in the United States. We will now present you with 5 questions that will reinforce the importance of recognizing glucose 6-phosphate deficiency and improving outcomes in newborns. Which classification of G6PD deficiency is associated with clinically significant chronic hemolysis? The answer is A, Class 1. A healthy infant born at 36 weeks gestation with no neurotoxicity risk factors has a total serum bilirubin of 10 milligrams per deciliter at 24 hours of life. What therapy would you recommend? A. Start intensive phototherapy. Repeat total serum bilirubin after 2 hours, and then every 4 to 6 hours. B. Check bilirubin in 4 to 8 hours with follow-up. C. Follow up within 2 days and recheck bilirubin in 24 hours. D. Prepare for an exchange transfusion. According to the AAP guidelines, and as reflected by the results of the PETI tool, either of the following answers is an acceptable treatment plan. A. Start intensive phototherapy, repeat total serum bilirubin after 2 hours and every 4 to 6 hours thereafter. Or B. Check bilirubin in 4 to 8 hours with follow-up. What treatment modality did you select? Did you consider all the neurotoxicity risk factors? As discussed earlier, the clinician should use the correct bilirubin nomogram and the assessment tool available at pedditool.org to help decide the next treatment step. In the graph shown here, which is the nomogram applicable to neonates without neurotoxicity risk factors, the bilirubin value falls below the threshold for phototherapy. Treatment options for this neonate are provided within the associated PEDI-tool analysis. A healthy infant born at 36 weeks gestation was determined to be G6PD deficient based on a low enzyme activity level. The newborn's total serum bilirubin of 10 milligrams per deciliter at 24 hours of life. What is the recommended treatment? A. Start intensive phototherapy. Repeat total serum bilirubin after 2 hours and then every 4 to 6 hours thereafter. B. Check bilirubin in 4 to 8 hours with follow-up. C. Follow up within 2 days and recheck bilirubin in 24 hours. D. Prepare for an exchange transfusion. The correct answer is A. Start intensive phototherapy. Repeat total serum bilirubin after 2 hours and then every 4 to 6 hours thereafter. This is the same neonate presented in the last case scenario, but with one vital exception. The infant is G6PD deficient. Given this information, use of the bilirubin nomogram for neonates with one or more hyperbilirubinemia neurotoxicity risk factors is warranted. Based upon the bilirubin level reported, this neonate should be treated with phototherapy. Comparing case scenario 2 with case scenario 2B, knowing the infant's G6PD deficiency status critically changes the course of treatment. Which diagnostic test is the most sensitive and specific for G6PD deficiency? A. Qualitative, semi-quantitative. Example, fluorescent spot test. B. Cytological. Example, blood smear for Heinz bodies. C. Quantitative G6PD enzyme measurement. D. Genetic testing. The correct answer is C. Quantitative G6PD enzyme measurement. If there is no acute hemolysis occurring, an accurate enzymatic activity level can be obtained. Quantitative testing is highly sensitive, which leads to a lower incidence of false negative results. Quantitative testing is also very specific to confirm if one is not G6PD deficient, thus lower incidence of false positives. Neither qualitative nor cytological testing provide the actual enzymatic activity level, leading to a lower incidence of accurate interpretation of the results. Although genetic testing provides evidence of the gene mutation, the clinician is left without the knowledge of the extent of the deficiency among heterozygous females, which is a valuable factor when assessing treatment options. Overall, quantitative testing is the most sensitive and specific way to determine if a patient is G6PD deficient. A healthy term infant's G6PD quantitative test results were received a day after the child was discharged, which revealed low levels of G6PD enzyme activity. At 48 hours post-birth, the neonate had no visible jaundice just prior to discharge. His total serum bilirubin level was acceptable for discharge. Which of the following treatment recommendations is appropriate? A. PCP follow-up within 1 week. B. Obtain a serum bilirubin as soon as possible with follow-up. C. Expectant management and track appearance of jaundice. D. NICU hospitalization for hemolysis evaluation. The correct answer is B. Obtain a serum bilirubin as soon as possible. This infant is not necessarily at risk for immediate hemolysis. However, the bilirubin level should be checked to rule out imminent hyperbilirubinemia. Optimally, all G6PD deficient neonates should undergo an evaluation with their primary care physician as soon as possible, so the infant can be assessed for the severity of the deficiency. Also, it is important that the parents be educated about G6PD deficiency so they can learn the signs of hemolysis and how to avoid known hemolytic triggers. By way of example, the mother's milk may carry substances that will trigger a hemolytic response in the G6PD deficient infant. How fortunate for this newborn's family to learn that he or she is G6PD deficient. We know that not knowing that a newborn is G6PD deficient can cause a cascade of events with the possible outcome of permanent brain damage. Given the knowledge that being G6PD deficient is crucial for a safer and healthier life, one should ask, why am I not screening for G6PD deficiency when a baby is born under my care? Thank you for taking the time to learn more about glucose 6-phosphate dehydrogenase deficiency and how to improve outcomes in newborns. It takes a community of brilliant minds to bring forth the science needed to prevent hyperbilirubinemia in newborns. For their exceptional work, the Foundation wants to recognize Dr. Vinod Bhatani and Dr. Sarah Milburn, who reviewed the assessment questions and provided invaluable feedback. We also wish to thank Dr. Alex R. Kemper, Dr. Thomas B. Newman, and Dr. Jonathan L. Slaughter for spearheading the 2022 AAP revisions. It remains the goal of the G6PD Deficiency Foundation to provide to you, the clinicians, information that will assist you as you evaluate and treat G6PD deficient newborns. If you are interested in the materials and data used to construct this educational module, those references can be found on our website at g6pddf.org. If you have any feedback, please reach out to our foundation through our website.